Thank you all for coming. Is that too loud? Do we need to turn it down a bit? No? Okay. Perfect. Okay, so for my disclosure statement, my name is Richard Bonato. Call me Rick. I started studying sleep in 1986. I'm a registered sleep technologist, both with the American Academy of Sleep Medicine and the Board of Polysomnographic Technologists. I did my PhD specializing in electrophysiology and experimental psychology. I used to run a sleep disorders laboratory at a hospital in Ottawa, Canada. That's where I'm currently living. And I used to teach a third-year undergraduate course on sleeping and dreaming. So the class sizes range from a small class of 50 up to maybe 200 people. And I did that about 8 times. That was a lot of fun. I really enjoyed that. But I got tired of grant applications. So in 1996, I left academia and went to go work for a company called Nellcor Puritan Bennett, and they invented the pulse oximeter. So you know your finger probe? So that was NPB, we called it, Nellcor Puritan Bennett. And worked there for a couple of years. We were doing about $1 to $2 billion in revenue because we had a merger after about a year. We merged with Mallinckrodt, and then the company got taken over by Tyco, TYCO, which stands for Take Your Company Over. And then that company became, they split. They were forced to actually split because even the IRS, their forensic accountants, couldn't figure out Tyco because their head office was in Bermuda for tax purposes. And the IRS, basically, the US government forced them to split. So one of the splits was Covidien. Covidien was the healthcare arm of Tyco, and on day one, they were a $10 billion a year company. So we actually created, when I say we, myself and Don Bradley, a couple of the co-founders of Braebon. I'm the Bon in Braebon. And we had actually met in October of 1991 and ended up creating a product which became known as Sandman, which was, it eventually got about 25% of the market share for the sleep laboratory or PSG product. So I've reviewed articles in the journal Sleep, and I'm a member of the AASM and the American Academy of Sleep Technologists and the Sleep Research Society. I used to be on the executive of the Canadian Sleep Society in the early 90s. I was on it with Mir Krieger, who was the president at that time. He's one of the editors of the textbook on sleep disorders medicine. It's called Principles and Practice of Sleep Disorders Medicine. Fantastic book. I think it's in its 5th edition now. So, you know, you can even use it for weightlifting because it's about this thick. And if you drop it on your foot, you'll probably break a toe. So I recommend that as a resource book that's quite heavy reading. Just want to point out there's an app that I wrote with Alan, and it's called the Dental Sleep Medicine Study app. It's free. It's on the App Store, the Apple Store. So essentially there's 100 questions that you can use and just kind of study, get a good feel for how comfortable you are with the concepts around dental sleep medicine. And that'll work on your iPad or your iPhone or your iPod Touch. So what is sleep apnea? Textbook definition, anyone? Exactly. So textbook definition is cessation of breathing for 10 seconds or longer. Right? So what I want you to think about it, I want you to think of it as wake up, gasping, choking, die in your sleep disease. There we go. So listen to the effort to breathe. Gasping. So that's actually a recording from the MediByte. So hopefully tomorrow, I can't guarantee we'll get some good apneas tonight, but maybe if you drink a lot of wine, we'll see more. But certainly tomorrow morning, hopefully we'll have some good snoring and some good apnea to review. But most of your patients don't know they have sleep apnea. If you describe it as wake up, gasping, choking, die in your sleep disease, you'll get their attention much better than if you call it sleep apnea. The key message there is most of your patients will have no clue that they've got sleep apnea. Because the best way to ask him, and what I want you to start doing next week if you're not doing it already, is just ask him, do you snore? Snoring is like an alarm telling you that there's something wrong with your breathing during sleep. We're not supposed to snore. So if you have a person who snores in their sleep, they're at higher risk for sleep apnea. When we talk about sleep apnea, we're often talking about a repetitive cycle during the night. So people stop breathing, they wake up, take a few gasps of air, and they return to sleep, their apnea resumes. Something I call the wheel of death. So what happens during a respiratory event? So the first thing is the person's asleep and they're snoring. People that snore are at higher risk. As the airway collapses and apnea occurs, the snoring stops. This is when we start seeing hypoxemia, or low blood oxygen, excessive CO2, hypercapnia. Person wakes up and starts breathing again, and the entire cycle repeats itself. And sometimes you can get that 100, I'll show you an example right now. Person stops breathing 100 times an hour. And the research has now found reduced brain matter concentration in patients with obstructive sleep apnea syndrome. In other words, your brain cells are dying, right? Your body can go weeks without food, days without water, but only minutes without air or oxygen. So the most important thing your body will do, right, is breathe, right? Exchange oxygen and CO2. Your heart's pumping. But it's amazing how often people don't think about that. So in one of these courses, this is actually from a course we did in, I think it was in St. Louis. This person here, see this flat line right here? So if you tell your patients they're flatlining, you'll get their attention. So in this instance, the flat line represents airflow. And this is 66 seconds. This is a dentist that we did at a course. And the next day we reviewed it. And he came up to me afterwards and he said, and his blood oxygen, by the way, right here is desaturating 34%. If he was in a hospital, they would have called a code. They would have called the code blue and the emergency team would have run into the room. Because if you're in an ICU and you've got a finger probe pulse oximeter and you go below 90%, you're going to get their attention. But he went down 34%. So he's down in the 60s at this point. So he came up to me after, because what we do is we review everything, and it was all anonymous, there's no names. He came up to me later and he says, I was looking at that. He was from Tennessee. He goes, I was looking at that and I thought to myself, that son of a bitch gonna die. Then he said, then I realized that was me. So we got his attention, and then he ended up emailing me the following week, and he said, because he got an oral appliance as part of the course, and he said, I think it's working, because I'm actually sleeping through the night. He goes, and he slept through the night 2 nights in a row. Saturday night and Sunday night, he slept through both nights, because this was done on a Friday night. And he said he can't remember the last time he slept through the entire night. It was probably decades, over 20 years ago. So that was, we probably saved this guy's life as part of that course. So here's another dentist, different course. His apnea-hypopnea index is 100. So that's 100 times per hour this person stops breathing or has difficulty breathing, either apneas or hypopneas. So if we talk about that wheel of death, say 1, you can see the arousal here. These are recovery breaths. You take a few breaths, 1, 2, 3, 4, stops breathing again. Some more recovery breaths, stops breathing again, some more recovery breaths. So if we talk about that wheel of death, we have 1, 2, 3, 4, 5, 6, 7, and that's only 5 minutes of the entire night. So that's 7 times. And each of those cycles are occurring here 7 times. Now you see here the blood oxygen level, it's going up and down like a yo-yo. That should be flat, perfectly flat in a healthy sleeper. So if we break it down in more details, we'll go over some of this tomorrow. There's your apnea-hypopnea index of 100. So that's the apneas plus hypopneas index, or per hour of sleep. This is the respiratory disturbance index, which is apneas plus hypopneas plus something else called RERAs, which we'll talk about momentarily. These are some just simple biometrics. That was not properly filled out. Total recording time, and here we have the blood oxygen level broken down in detail. The number of desaturations of 3% or more were 606. Normally on a healthy sleeper, you might get 10. So this person is literally dying in their sleep instead of their body getting restoration. There's probably about 30 or 40 theories as to why we sleep, but the number one is body restoration and brain restoration. And we know that there's an increase in growth hormone secretion during deep sleep, and we know that during REM sleep, there's improved memory consolidation, both in animals and in the human research literature. They found that if you deprive an organism of REM sleep, you interfere with learning. So there's theories that REM sleep has a slightly different function than deep sleep. This person, however, is not getting anything. They're just continually arousing. When we say arousal in sleep, we're talking from a deeper stage of sleep to a lighter stage of sleep. So this is this person's sleep broken down for the entire night. Here you see the snoring volume between 50 and 100 decibels. Here you see the SpO2, or the saturation of peripheral oxygen. Sometimes in the literature you might see SaO2. That stands for the saturation of arterial oxygen. SaO2 is actually taken from blood gases, where you have to draw the blood with a syringe and then send it to the laboratory. So if they're using a finger probe and describing it as SaO2, that's technically incorrect. It's SpO2. This line here is what you should look like the entire night, flat. But you see how here it's going up and down continuously all night long. Each tick mark here represents the occurrence of an obstructive apnea, or OA. CA is central apnea. We'll talk about that momentarily. MA is mixed. Hypopnea is HY. Each of these tick marks right here is D is for desaturation. Now let's compare that to a normal sleeper, or a good sleeper, because no one's really normal per se, but here's a good sleeper. You see the difference? Snoring volume, top line here compared to this. Let's look at the SpO2 here compared down here. See how this is flat? It's more or less flat all night long. That's exactly what you want. This person's apnea-hypopnea index was 2.6. Anything less than 5 for an adult is considered within normal limits. So that's good. If it's a child, the clinically significant cutoff level is 1. So for a child, an AHI of 1 or more is considered clinically significant. For an adult, it's 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is severe. So one of the causes, of course, of sleep apnea correlates with obesity. It's not caused, however. I mentioned earlier the craniofacial article that compared Caucasians and Asians. So you have to keep that in mind. However, roughly 60% of people with severe sleep apnea or with some type of sleep apnea have obesity. So it does correlate rather well. So let's take a look at the obesity trends. 1990, this is from the Center for Disease Control, the CDC. They're defining obesity as a BMI of greater than or equal to 30, or about 30 pounds overweight for a person 5'4" tall. And let's go year by year. This is 1985. See how here there's 2 categories? Let's watch what happens as a trend. 1986, you notice the colors are getting darker. 87, 88, 89, 1990. Oh, new category just showed up. Mississippi and Louisiana helping to lead the way. Keeps getting darker. Now we're into 94. Much darker. Oh, new category. 15% of the population now. And again, Mississippi. No, Alaska's on the list now, a little bit of Hawaii. Oh, new category again, and look who's leading the way. Now we're into 2002. Still getting darker, another new category. Still the same trends. Or at least shall expand again. Now, this was just released in May of 2012 from the Center for Disease Control. The current obesity prevalence is 34% in adults in the US, 17% in children and adolescents. They're now making predictions for the next 18 years. They say by 2030, for severe obesity, people roughly 80 pounds or more overweight, they're predicting an increase of double from today's 5% to 11% in the future. In their estimates, this is from the CDC, we will go from 34% or roughly 1 in 3 Americans to 42% in 18 years by 2030. So the market trends are there. It's going to get worse, not better. So when you're talking with your patients, and I was having this conversation earlier with DeWitt, the key thing here is you want to talk about the overall impact on health, right? There's research out there that suggests that if you floss, you can also reduce cardiovascular disease. Well, if you can treat sleep apnea with oral appliances and also encourage improvements in diet and exercise, it can all go hand in hand. So let's talk about sleep. What is it? When we say sleep apnea, we're talking about sleep. Sleep is a known state, right? It's an altered state of consciousness. There's changes in neuronal firing patterns. We know that if we put electrodes on your scalp and we have certain levels of amplification and filtration, we can actually record brain waves. And when that was discovered in the 1930s, they started naming the brain waves according to the Greek alphabet. So they started with like alpha, beta, gamma, delta, and so on, theta. Now, we say consciousness is usually in abeyance. When I say abeyance, so it's usually suspended because there are bona fide cases of people being in what's called polysomnographic sleep, where they're definitely in REM sleep according to all the fancy machinery we have, but part of their brain and part of their mind is still alert. So that was published by UCLA, Dr. Stephen LaBerge, in the early 80s. And that's called lucid dreaming. Some of you might have even experienced that. And that's often common in the Eastern meditative techniques, where people will often be in a dream and then they are aware that in fact they're dreaming. And to some extent, you can actually control that dream as well. So that's why we say that consciousness is usually in abeyance. It's usually suspended, but not necessarily. And then there's body and tissue cerebral restoration that I just mentioned a few moments ago. We have reduced awareness, but it's not completely absent. So the common example would be mother's ear. Right, a mother who has a baby in the house will wake up very quickly if the baby squawks or cries, but they'll sleep through a thunderstorm. So part of your brain is always monitoring and filtering the environment. From an evolutionary perspective, it would be really bad for us to completely shut down. To measure sleep stages properly, we need to measure at least 3 things. EEG, or electroencephalography, which are brain waves, EOG, or electrooculography, or eye movements, and EMG, right, electromyography. We typically record the EMG from what's called the mentalis and submentalis areas, right here on the chin, because this is the best place to actually measure what's called atonia, or the drop in muscle tone associated with REM sleep. Think of REM sleep as an active mind in a paralyzed body. That's the easiest way to think of it. And for sleep researchers, we usually say there's 3 states of existence: wakefulness, non-REM sleep, and REM sleep. So the non-REM sleep has a very different characteristic patterns of EEG, EOG, and EMG. The first sleep stages were described in 1937 in the Journal of Experimental Psychology. We're still using the same technology today, fundamentally. Slightly different in what we call it. Like back then they called it stages A, B, C, D. Today we call it 1, 2, 3, and REM sleep. In 1953, Dr. Nathaniel Kleitman at the University of Chicago, they published an article, Azarinsky and Kleitman, in the journal Science. And that's when they discovered REM sleep. 1957, they had to revise the 1937 sleep stages to include REM sleep. And again, it was further revised in 1968. And then in 2007, the American Academy of Sleep Medicine revised it again to include kind of abnormal sleep disorders and breathing and arousals and periodic leg movements, because the 1967 manual was only to describe normal or normative adult sleep stages. So fundamentally, we're still using the same technology as the 1930s. So we're not going to record sleep stages this weekend, because what we're more concerned about is breathing during sleep, and not necessarily concerned about how people sleep. We're concerned about their breathing during sleep. Typically, the patients with sleep apnea sleep fine. Their problem is they're excessively sleepy. So think of sleep apnea as a disorder of breathing, not a disorder of sleep per se. So here's the changes that we often see. Stage 4 sleep is now being combined with stage 3. So they just call it deep sleep. Researchers were calling it that for years. The fundamental thing here to notice is the drop in muscle tone to its lowest point during REM sleep. And during REM sleep, you have a paralyzed body. So there's alpha cord motor neurons, which are hyperpolarized in your brainstem. And think of that as a door that's closed. So the active mind sends signals, or your brainstem sends them to the midbrain and to the forebrain, simultaneously sends them down to the medulla. But if that door is functioning properly, the door is closed. So the signals don't go anywhere, right? They're not going down your spinal cord and activating your muscles. But there is a sleep disorder called REM behavior disorder, typically older men. And what happens there is they literally act out their dreams. And they can often have like superhuman power during sleep, where these guys will literally bounce out of bed head first into a wall and hurt themselves. So that's called REM behavior disorder. It's very rare. I remember diagnosing that in the sleep lab years ago when we had the recording. It was really interesting because the couple came in and she had a black eye. And typically what happens with these older men is they get violent. Their dreams typically get violent. So he had a dream where he was in a fight and he punched while he was in bed, and he ended up punching his wife in the face. And next thing you know, he's being hauled off to see the psychotherapist and what's going on. And they were really upset, obviously. So he came to the sleep lab because the problem was happening during sleep. And you read the textbook, you see the case, you have an infrared camera, you've got the recordings going on, and instead of the muscle paralysis that you see here, instead of this flat line that you see right here, right there, instead of that flat line, you end up with twitches. And so this person was literally punching the wall and acting out during REM sleep. So the doctor was able to make a diagnosis. We collected all the information. And when they came back, it was amazing. The visible relief on the couple was just truly amazing. So the point there is there are things you have to know to separate or differentiate some of these sleep disorders from one another. This is the breakdown that we typically get in this is called a sleep histogram or hypnogram. So when someone goes to a sleep lab, how many people have been to a sleep lab and slept in a sleep lab? So about 4 or 5 of us. So typically what happens is you go in there and they put electrodes. They have to rub your skin lightly because the surface skin is an insulated barrier. And so what we do is we just abrade or get the skin abraded slightly, put the electrodes on certain locations, and then put some tape on there. So we put them on the scalp for brain waves, and next to the eyes for eye movements, and under the chin for muscle tone. Then you put on some of the equipment we'll be wearing tonight, belts for ventilatory effort, the finger probe for blood oxygen level. We'll put electrodes in the sleep lab. They'll put electrodes on your legs for leg movements. And then the person probably has about 20 or 30 things attached to their body. And then you've got the person in a strange environment, in a strange bed with a strange pillow, with a stranger watching them and an infrared camera. And then you say, okay, go to bed and have a really good night's sleep, just like you do at home. So one of the controversies is which is more accurate. We usually say a sleep lab is a more accurate test of a less accurate night's sleep, and a home sleep test is a less accurate test of a more accurate night's sleep. So I personally think a home sleep test is much more convenient, cost-effective, comfortable, and more accurate overall for what we're looking at for snoring and sleep apnea. Some of the sleep disorders, like REM behavior disorder, epilepsy, some of these other sleep disorders must be diagnosed in a sleep laboratory. So when you go into a sleep laboratory, they put all this equipment on, you have a sleep technologist in attendance. The short form for a sleep lab test is called PSG, or polysomnogram. It's a Latin-Greek hybrid term. And they break down the sleep stages according to EEG and EOG and EMG, and they break it all down into, this would be a beautiful night's sleep right here, because the person doesn't wake up at all until the end, right? Until they get out of bed. So this is wakefulness here, at the beginning and at the end. Stage 1 sleep. Think of stage 1 sleep as light to heavy drowsiness. It's not bona fide sleep per se. If you wake up people from stage 1 sleep, the majority of them will say that they were not asleep, that they were in fact kind of drowsing, dozing off, so to speak. Stage 2 sleep is where most researchers, including myself, would say real sleep begins, because the brain waves that occur during stage 2 sleep are unique to sleep and don't occur at any other time. And then stages 3 and 4, you combine those now just into deep sleep. Now REM sleep, they chart usually at the top, closer to stage 1 sleep. And as the night goes on, what you'll notice, if I draw a line right here at 4 hours, the second half of the night is predominantly REM sleep and stage 2 sleep. The first half of the night is predominantly deep sleep with less REM sleep. And as the night goes on, your REM sleep gets longer. The REM sleep periods get longer. So the REM sleep periods are roughly every 90 minutes. It's called an ultradian rhythm. You have circadian rhythms, which are about a day long, your wake sleep cycle. You have ultradian rhythms, which are about 90 minutes in length. And the non-REM REM sleep cycle is an excellent example of an ultradian rhythm. They've actually extrapolated that. Kleitman wrote in his book in 1963 about the basic rest activity cycle, and he extrapolated this non-REM REM sleep cycle to wakefulness, and they've actually charted that smokers, for example, will have a cigarette roughly every 90 minutes. People take coffee breaks roughly every 90 minutes. So they've extrapolated that and said this is an extension, and during the daytime this extends to the basic rest activity cycle, where they've actually plotted bathroom trips and quite a few things. So the first half of the night is your deep sleep, and during deep sleep is when those things like sleepwalking, sleep talking, and those parasomnias, those sleep disorders called parasomnias will occur. And the second half of the night is when you typically get more of the REM sleep. During REM sleep, we are most susceptible to having problems with breathing and problems with snoring at night, because that's when our muscle tone is at the lowest. That's when we have the maximum susceptibility for upper airway collapse, because we have the lowest level of muscle tone. If we are in REM sleep on our back, we're even further worse off, because gravity will pull the soft tissue against the posterior of the pharyngeal wall. So you'll get some people, and I'll show you some cases shortly, you'll get some people that only have sleep apnea when they're on their back. So the EEG during sleep stages, we have, this is called the arousal continuum. And at the very lowest level is death, of course. At the highest level will be mania. We have anxiety, everyday wakefulness, relaxed wakefulness. If you close your eyes and you put electrodes at the back of your scalp, about 80% of the population, 4 to 5 people, if you close your eyes and have them sitting relaxed wakefulness, lying down or sitting in a chair, they will show what's called alpha EEG activity, which is what you see right here. It tends to be very rhythmic. It's about 8 to 12 cycles per second. As it slows down a little further, we get theta waves. And if it slows down further still, you'll fall asleep. K-complex, sleep spindles, these are unique to stage 2 sleep. And when you get really deep, what's called deep sleep here, that's when you get the tall, slow EEG waves. This is the stuff that they record in the sleep laboratory. Now REM sleep, what you'll notice is that the REM sleep looks more similar to the stage 1 sleep, which is why on the previous chart here, they plot the REM sleep on the same level as stage 1. And in fact, in the animal literature, stage REM sleep is called paradoxical sleep because it's very similar to wakefulness and is considered a paradox. But in humans, stage 1 sleep and REM sleep tend to be much more closely aligned. So the stages we break down, stage 1 non-REM sleep characterized by, it's about 5 to 10% of your night's sleep, slow eye movements, slow breathing, regular heartbeat, drop in blood pressure, decrease in brain temperature, low voltage theta EEG. And this is when you might be falling asleep and you'll see an image and all of a sudden you'll kick out. It's called hypnic jerks. And they can be benign if it happens infrequently. If it happens too much and interferes with sleep onset, then it's a problem. Stage 2 sleep is about 45 to 50% of your night. This is what we would call bona fide sleep. So again, your body's just slowing down even further until you hit stage 3, non-REM, deep sleep. And if someone was to wake you up from this stage of sleep, this is where you would say you're groggy, you're confused. If you wake up a child from this stage of sleep, you're more likely to have an episode of sleepwalking or sleep talking. This was coined, the term in the 1960s, it was called disorders of partial arousal. That's because part of your brain wakes up and part of your brain doesn't wake up. And then REM sleep, muscle paralysis. That's the key part here as far as we're concerned. And the muscle tone is lowest during REM sleep, and apneas and hypopneas are at their worst during REM sleep, particularly when you're on your back. So the treatment for sleep apnea. Number 1 treatment, CPAP. Anyone ever tried it? Anyone still using it? Okay. I've tried it. I lasted about 3 hours on CPAP. I've been wearing an oral appliance for over 5 years now. It works 100% of the time if people wear it. And that's the biggest problem with CPAP. Probably after about a year, national US average is about 50% of the people stop wearing their CPAP. These are some of the pieces of equipment. So when you see right here, this is the older generation. So the three big market leaders, you've got Philips, which used to be called Respironics. ResMed is from Australia, and then Fisher & Paykel is from New Zealand. Fisher & Paykel got into it because they were making ventilators, and I think it was Respironics or somebody approached them, and they took their old, in the southern hemisphere particularly, Fisher & Paykel white goods, they sell like appliances for your home, and they took one of their washing machine motors and hooked it up to a CPAP, and that was one of their first CPAP machines. It's for one of their dishwasher motors. So here, this is the latest generation, Philips, and this looks more like a Bang & Olufsen piece of equipment, you know? They're trying to make them more glamorous, less medical. The newest icon from Fisher & Paykel here looks like a clock radio, right? That's something that you put beside your bed. And now that you've even got iPod docking stations, so you can actually, I believe, connect this to your iPod and wake up to music and program the little clock. And see here, it looks much more, this is their previous generation. See, that's your water reservoir. And you've got a 6-foot piece of tubing that comes out. And the downside, of course, is you have to really clean these things. Because what do you get? What are your higher likelihood of getting fungus and mold when you have heated, humidified air? So it's really important that patients clean this. And they have to travel with the CPAP. So you've got backpacks that are made, and you have to take it out and going through security. I think in one of your articles, Alan, you even said that going through the airport, they said take your laptops and CPAP out going through the security. So here's some of the comparisons side by side, oral appliances versus CPAP. Now, the American Academy of Sleep Medicine will say that CPAP is a first line of treatment for anyone who's a severe sleep apneic. In a 2006 paper that's on your memory stick, They do now say that for primary snoring, mild and moderate apnea, an oral appliance may be chosen as a first line of treatment. But when you talk to the people in the field, we're at trade shows, and you'll get sleep technologists, they'll walk up to you, they'll get the oral appliance, and they'll look at it, and they'll say, "Is this an oral appliance?" And you'll say, "Yes, it is." These things really work, and you get that all the time. I still get that in sleep labs all the time. Do you want to get the microphone? You have to turn it on. I think it has a 2-second delay.
Yesterday I saw a patient of ours, and we were handing out a little letter to our patients about sleep appliances and sleep disorders, and she said, "Can I get one of those, because I hate my CPAP?" And so we called her physician, who I know, and he sent her sleep study over. She'd had a polysomnogram, and her number was, her AHI was 6, and she's been wearing a CPAP for like the last 3 or 4 years.
That's incredible. And in our local, like the sleep lab where I used to be the manager, and so I train the staff that's there now. The director, I was talking with him a couple years ago, and he had said to me, if he's got a patient with an AHI of 8 or 9, he wants the local dentist to have one of our devices, one of our recorders, because then he just wants to get the report back. It's the same technology he uses in the sleep lab. In fact, we supply the lab with our sensors. And he said he doesn't want to bring that patient back, and that was an AHI of 8 or 9. And he said, there's no way I can justify the cost and the expense of bringing the patient back for a full PSG into the sleep lab with such a low AHI. And I know of other labs that use a cutoff of 10. I know other labs that use a cutoff of 19 or 20, even though the AASM will still say 30. So it really comes down to the philosophy of that particular medical director and that particular facility as to whether they're going to go straight to CPAP or whether they're going to use a cutoff that's a little more reasonable. Flick it on.
I was reading through my notes from previous courses I've taken over the years on sleep medicine, and there was a note that said that the CPAP machine can contribute to the development of central sleep apnea.
Yes, I was going to show you a case, but you're getting about 2 slides ahead of me.
Sorry.
That's all right. We'll talk about that in just a second. CPAP side effects, I'll talk more about that in another slide, but there's a lot of side effects they don't talk about. Noise in the machine. I've shared hotel rooms with guys, and they roll over in the middle of the night. All of a sudden they develop a leak, and it's like you're next to the ocean where you hear thinking if you're the bed partner and you're only this far away as opposed to being on several feet away, you could have a stream of air shooting at you for hours during the night. Infections, runny nose, that's quite common. Headaches, ear pressure, that's what I had. That's why I couldn't last. Air in the stomach. Tubing gets in the way. The air is too hot or too cold. CPAP face is my favorite. There's companies out there that now sell you soft padding because the headgear will make lines, and you wake up with lines on your face in the morning. So there's companies now that will put little soft pieces of cloth over top of that. Oral appliance side effects, all of these already. As far as teeth movement goes, I know Alan's going to talk more about that, but if you follow the literature from Dr. Alan Lowe, he talks about 50% of the movement is neutral, and then 25% is actually positive, and 25% might be negative, but it's not something that can't be dealt with using conservative dentistry. So nothing to get really excited about, according to what Dr. Lowe lectures, and he's, of course, is a professor of dentistry at UBC.
I just wanted to add something, that the CPAP, the straps, if they're not directed a certain way, will promote a temporomandibular joint problem.
Yeah, that's a good point. Yep, certainly, and I know a lot of the CPAP companies were starting to get into pediatric CPAP, which was the next big thing. And of course, then you start talking to craniofacial issues and introducing retrognathia. Last thing you want to do, as opposed to something like some good functional ortho can actually cure it lifelong, as opposed to a Band-Aid treatment for children. So one of the points I want to make as well is you can do combination therapy. And I think that's an underutilized avenue. Is for patients with high pressure CPAP, let's say above 12 centimeters, where you can combine that with an oral appliance, you can actually reduce typically the CPAP pressure by about 50%. So we had one dentist at, I think it was a trade show a couple years ago in Minneapolis, came up to me and said he was originally at 16, made himself an oral appliance, and measured himself both at baseline and then, of course, with the follow-up, because you've got a little adapter, and he said his pressure went down to 9. So this is how you just tee into a CPAP circuit right here. And what that does is you can actually record the CPAP pressure all night long at the same time as wearing an oral appliance. So here's a report that you would get. And this person, we did an overnight test. This is actually one of our board members. And he had an auto PAP. So the idea is that you have an automatically adjusting CPAP, or what's called auto PAP. And his pressure went from 5 to 8. And for the most of the night, he was at 6, which is 271 minutes. And here you see the pressure throughout the whole night, right down here at the bottom. So when you go into your practice, and if you're not asking your patients, do you snore? You also need to ask your patients, do you have a CPAP? Have you been diagnosed with sleep apnea? Do you have a CPAP? And if you don't ask them that question, you know how people talk about low-hanging fruit? Well, if you don't ask them, are they wearing their CPAP? That's like the fruit that you're squishing with your feet walking into your office Monday morning. Because about half the patients that have CPAP aren't wearing it after about a year. That's a national average. And so the side effects, of course, we talked about earlier a bit: claustrophobia, skin irritation, sore nose, air leaks, stomach bloating, chest or lung pain, dry mouth or throat, nasal congestion, eye irritation. So CPAP intolerance, when adherence is defined as greater than 4 hours of nightly use, 46 to 83% of patients with sleep apnea do not adhere to treatment. And that article is also on your memory stick. So the CPAP intolerance market is potentially huge. CPAP is the #1 treatment for apnea. You got a whole bunch of different masks. Huge amount of money is put into R&D on different masks. So you can make the sleep labs look better. A lot of times people talking about taking CPAP away. You never want to do that as a dentist. What you want to offer is an alternative. But even with that, you can combine CPAP therapy with oral appliance therapy in some cases and do something better. So this is actually from the article on your memory stick by Chan and Sestouli that was published in 2009. Now the solid line here is the oral appliance, and the dashed line is CPAP. And what they do in this article is they actually make the argument that in terms of health benefits, symptom control, adherence, tolerance, patient and partner acceptance, convenience, and affordability, oral appliances are as good or better than CPAP. And it's only on the PSG measures where the CPAP is usually shown to be better. Yep.
Could you clarify for me, if we reduce the pressure of the CPAP, why is that a positive?
Because a lot of times patients with high pressure CPAP have problems tolerating that. Think of sticking your head out the window going 10 miles an hour in your car and trying to exhale versus going 50 miles an hour and trying to exhale. And so for a lot of people, if they can get that pressure down below 10, that's huge. So as far as dental sleep medicine markets are concerned, snoring really is the biggest market that's out there. 50% of the general population snore, and about 5 to 10% have severe sleep apnea. In between, of course, the huge markets of mild apnea and moderate apnea. These really are the target markets for dental sleep medicine, and of course CPAP intolerance. So if we just look at these 4 markets, 1, 2, 3, 4, and forget about severe sleep apnea for the time being, you've got the largest chunk of that pie, which is a target market for dental sleep medicine. I always tell dentists, if you have a patient that walks in and they're pulling an oxygen concentrator behind them, or they've got other comorbidities like COPD, Parkinson's, Cheyne-Stokes, they've got other problems, they're on a pacemaker, just send them straight to the sleep lab. Don't even mess with that. The sleep labs of the future are really going to be dedicated towards those patients with comorbidities and the difficult to diagnose patients, the people that are really sick. In 2008, here in the US, the federal government, Medicare, Medicaid, CMS, actually approved home sleep testing for the diagnosis of sleep apnea to permit reimbursement of CPAP. And within a couple of years, companies like Aetna, the insurance, the private payers, actually started changing their insurance programs to require pre-authorization for the sleep lab test, but no longer requiring pre-authorization for the home sleep test, which is a complete reversal of what it was prior to that. So that March 2008 ruling was really a watershed moment. And it's taken, the sleep labs are kind of being pulled kicking and screaming into the 21st century to embrace the home sleep testing technology. So everything we're talking about here this weekend, this is not difficult. It's a lot more difficult for you to do, a root canal. Doing oral appliance therapy for snoring and sleep apnea does not involve blood, but you're not going to make a root canal without taking an X-ray. In the same analogy, you're not going to want to do oral appliance therapy with some type of recording device to monitor it. So if you're charging $3,000 for an appliance and you're doing it, say, 40 weeks a year, you can add $250,000 to your top dollar revenue. And your auxiliaries are key. They can probably do about 80 to 90% of a lot of what's going on. So what tools and ingredients do we need to know if this person really has sleep apnea? Well, we got to do a comprehensive intake. On your memory stick, there is a questionnaire here. And in that one, it's a 2-page questionnaire. It has the Epworth Sleepiness Scale. And the Epworth Sleepiness Scale is a simple questionnaire, and it has 8 questions that are ranked 0 to 3, each question. Any score above 10 indicates pathological sleepiness. So that's used worldwide. It originally came from the Epworth Hospital in Melbourne, Australia. There's also the Berlin questionnaire, which is a little farther down, and that questionnaire asks very specific questions about snoring. And on page 2, on the second side, there's some questions about medical history. So we actually have a program in place that takes that 2-page questionnaire, combines that with MediByte data, and we can actually get a registered sleep technologist to score that and actually get a board-certified sleep doctor to sign off on that for a diagnosis. So after you do the comprehensive intake, you want to do a baseline test. You want to know, does this person really have sleep apnea? So when to use it? You suspect snoring, you see abfractions, wear and tear in the teeth, you suspect sleep bruxism, you see scalloping of the tongue, bed partner reports of apnea. When you do the Epworth Sleepiness Scale, not only should you have the patient fill it out on themselves, have the bed partner fill it out on the patient. Because chances are the ESS or Epworth Sleepiness Score will be higher when the bed partner fills out the questionnaire on the sleeper or on the patient than when the patient does it themselves. So you want to use a home sleep test when you're doing oral appliance evaluation or follow-ups. Even if you get a referral from a sleep lab, so you get a medical doctor who sends you a patient, you want to do a baseline test. Because what can often happen is you'll have a PSG measure and you're not going to be comparing apples to apples. As a dentist, you always want to do at least 2 tests. You want to do a baseline test, and then post-appliance delivery, the patient's been wearing it 3 or 4 weeks or longer, you want to do a second follow-up test. When you see an Epworth Sleepiness Scale score above 8, even if the patient comes in with morning irritability, it's often a red flag for sleep apnea. I'm going to talk to you later about my father-in-law, who's a retired dentist, and his experience with atrial fibrillation. Children with attention deficit hyperactivity disorder. In the literature, they think 25% or more of children with ADHD are not actually bona fide ADHD patients. They may be undiagnosed sleep-disordered breathing. So that's another large market that's out there. Any questions so far? Microphone? Gout? Yeah, I think it's the uric acid in the body that changes at night from the apnea, causing that and then causing the deposits to form. I've read case studies where people went on CPAP and then within 6 months, the gout disappeared. And I posted that on a sleep technologist forum. 2 or 3 of the other sleep techs responded, yes, they actually had that personal experience. There was a short booklet that was written by a person who had gout, who had sleep apnea, undiagnosed, treated with CPAP. The gout went away within 6 months, called the rheumatologist. First, he was incredibly excited to continue the conversation. And then about a month later, the patient could not get the phone calls returned because it turns out that they would be cutting into the revenue stream of the rheumatology. And there was nothing in it for him. And I've been finding the same kind of experience with cardiology to a certain extent. Because if you treat the sleep apnea, you can cut into stents and other types of delivery of drugs. Can I get a couple new AA batteries? Maybe you can find Peter to do that? Thanks. This is also on your memory stick. This is a very straightforward kind of clinical workflow. Nice and simple. I like to use it. The idea here, we talked about the comprehensive intake. You got your baseline test. If the patient has mild to moderate sleep apnea, they can get you weight. You want to make sure you've got a physician that actually makes a diagnosis. Dentists cannot make a diagnosis per se of sleep apnea by law. A medical doctor has to make the diagnosis. And then, of course, once you have that, they say, yeah, you're free and clear to make the oral appliance. And then you want to do a follow-up test and repeat as necessary. And I know Dr. Moses has told me he's done as little as 2 tests on a person and as many as 12 over a span of 2 years until they got it right. But even if you refer the severe or the moderate patients to a sleep lab, about 50%, you want to keep in touch with these patients because about 50% within a year or so are not going to be using their CPAP therapy. So those patients should be coming back to you. Question?
Yes, exactly on this point. So you have a patient come in that snores and you do a home study and they come back and they're 8, something like that. So they're in the mild level. You in Brabant have the service available that if we used a MediByte, we could send you that study, and do you have a physician on staff
correct.
That can review it and give a diagnosis?
Right, and they would be licensed in the state in which the test took place.
Okay.
So we would need to know if they're in Ontario, Canada, we have to use a physician who has licensure in that state. If they're in Texas, we need to know if they're from Texas because then we have to make sure that that doctor is licensed for Texas, okay. And so on, and all the, whether it's British Columbia on the West Coast or California or what have you.
So in that case, which we'll call mild, then through your service with the physician, we could get the diagnosis and prescription to make an oral appliance?
Yeah, typically we do the diagnosis. If you need a prescription or a letter of medical necessity, you might have to go back to their family doctor.
To their family doctor.
Yeah,
okay.
Which usually if you just send them a form, you fax it in,
yeah.
that they'll just sign off on it and fax it back to you.
Yeah.
As long as you've got a piece of paper from a board-certified sleep doctor saying this person's been diagnosed with sleep apnea. Now, if the patient comes back and they say their AHI is like 11, but they've got comorbidities, there's a good chance they're still going to be recommended to go to a sleep lab with a CPAP first. Because if they've got hypertension and it's high and there's a history of something else, they might say, well, you know what, to be on the safe side, we should send this person. I'd like to use a cutoff of about 20 because I like to be a little more conservative because I say if the AASM is saying the cutoff is 30, I like 20 only because it's just more conservative. But we've had cases here at these courses where people have gone from 41 to 10 in one night. And it's pretty. Now, one of the cases I'll show you later, he was at 16, I think he was at 16.8. It was a dentist and walked up Sunday morning and asked me how he did. I said, I haven't looked yet. And he went from 16.8, I think, or 16.4 to 3.8. And he said he felt great. Turns out he was being treated for depression. But it turned out to be the sleep apnea that was lowering the energy level. Yes? Here?
Instrumentation.
Is it on?
Okay. between the physician's interpretation and the patient coming back into the office for the adjustment of the oil appliance, it's usual in the Netherlands that the patient also goes to the, what do you call that, ear, throat, nose physician.
Okay. Mm-hmm.
And they always check with a sleep endoscopy if there is a tumor or tonsils that has to be taken out or anything else. Is it not the usual thing to do here in the States?
I don't believe it's a requirement, but I don't know. Alan, do you want to comment on that and your experiences?
If I'm understanding what you're saying, you're asking the question, don't the patient get referred to another physician for help? In other words, I don't understand. We would refer, or we would get these referrals if there were problems. We like to, what we do is multidisciplinary. Yes, we like to be involved with them. My best referrers are ear, nose, and throat doctors. A lot of times they'll refer because they don't want to do surgery, because the surgery for this stuff is so ineffective. In other words, I say, would you do a filling or would you do a dental procedure if the success rate were 45%? The answer is probably not. And so when they're doing the surgery, a lot of times the success rate is so low that the surgeons are, quite honestly, in good faith, trying not to do the surgery. And they'll say, listen, do this first. It's non-invasive, it's painless, try this first. So we involve ourselves with a lot of specialties, and the thing I could say is we don't know which specialists are going to refer to us. One of the unusual things that we have in children, if they see the large tonsils and adenoids, we were talking about that with Jan, they don't want to take them out often, but that's usually the way it goes. Adults, they don't usually like to do tonsillectomy, adenoidectomy anymore. They have a very high morbidity rate. I mean, patients could die from that. So they don't like to do that, even though these things are sitting there in the throat and they look like they're in the way, and they are. That's a hard surgery to get cooperation with. The palatal surgeries, very poor results. The nasal surgeries, where they make the airway bigger or cleaner, those are getting much better results. We're doing a lot better with psychiatrists recently. Psychiatrists see this as the cause of the depression, and sometimes they're getting better and better at referrals. Primary care, internal medicine people, yes. And again, they're all getting better, but the poorest are the cardiologists, the best ear, nose, and throat. But it's a whole spectrum of medicine that we can help with.
And shortly I'll talk about some of the research around the nasal breathing and why that's important. We'll be talking about that throughout the entire weekend. So this is just a setup real quick to go through. And this has already been done for you. So everybody's sleeping with a MediByte tonight. We just entered in first name, last name. We put in the weight. The default is 100 pounds. It used to be 200 pounds until we got a call from a dentist whose patient got really, it was a woman, female patient. She got really upset because the report came back and they didn't change the weight. And it said 200 pounds and she was really upset. So we changed that to 100 pounds. But they used to say something like 6'4", 100 pounds. And that was a really low BMI. So we changed that. Now, this is just the wizard that walks you through. So everyone tonight is going to use a snore microphone. You could use a CPAP, but no, we're not doing that tonight. By just checking that box, it shows a CPAP. And then they're all automatically programmed to start tonight. I believe, Gloria, what time did you program it for? 10 p.m.? 10 p.m. tonight, so you don't have to flick any switches or anything like that. It'll start at 10. It'll go for 9 hours. It'll stop at 7 in the morning, regardless of whether you're plugged in. So if you happen to plug yourself in at 11 p.m. or midnight, that's fine. Hopefully you don't forget. Hopefully you don't have too much wine or forget to plug yourselves in. But it'll go from 10 o'clock tonight up until 7 in the morning. We're just going to do one night tonight, and then we'll download the data, talk about it some more, and then we'll do a second study tomorrow night. This is just a summary screen that shows you at the end. This particular study was programmed for a CPAP. That's it as far as that goes. Now, everyone in your folder should have this, a laminated guide. If you can study this and remember everything on here, you'll do very well. You'll be able to talk extremely well with sleep physicians, sleep technologists, your patients. If you want more of these, let me know. And did you find yours? Everyone has one? Okay. So we often get requests from dentists who want 15 of these because they happen to have 15 operatories. So they often keep these chairside and they just reach for them and they explain to the patient, and quite simply, if you look on page 1, normal breathing, and you look down the column, this is what we want everyone to look like. This is your airway cross-section, right? The largest caliber of your airway. The tube is at its biggest. The flow through the airway is unobstructed, the most air flowing through. This is what we're going to see tomorrow morning. So tonight, when you're breathing in and out, you breathe in. This is the pressure waveform. And when you start seeing a slight reduction in the airflow or in the caliber of the airway, it's a phenomenon called flow limitation, or limited flow, right? Limited airflow. The caliber or size of the airway begins to be reduced. You start getting a partially obstructed airway. There's less air going through. You get a flattening on this waveform. Instead of being sinusoidal or quasi-sinusoidal, it begins to flatten. And what that indicates is snoring and upper airway resistance. So you'll start seeing, and you'll start hearing it because we're going to be recording the microphone tonight. And just as a caution, everything, as soon as it's plugged in, it starts at 10 p.m. If you're having any private conversations with your spouse or anything like that, keep it in the bag or keep it in the box or whatever supplied to you, because there's sometimes too much information on the recordings. So I was at a trade show a few years ago, and I started saying that to a group of about 5 or 6 docs. And the one guy started laughing just off by himself. And he came up to me privately later and said, you know, it's funny you said that because that happened to me one time. And he told me the story about it. But you have to tell your patients that when it's plugged in, it's going to start automatically. It will record everything. Now, Alan likes it because he can tell when the patient's watching television and when they turn the lights out. I've actually had one of the studies, I think in March, where the entire night the TV was on. You could hear the TV in the background, but only when there was apnea. This person had an apnea-hypopnea index. I think it was that guy who was 49. And when he was snoring, of course, you couldn't hear the TV in the background, but during the apnea, there was complete cessation of snoring, you could hear it. So when we look down here, this is what the waveform will actually look like. You see how here it's pretty constant? The amplitude's the same. This is the airflow pressure waveform. When we start seeing a drop from this peak and goes down, that's called the event. This was what we would call a RERA, normally a respiratory effort-related arousal. So the software counts that, and we could have a human registered sleep technologist validate that to make sure it's a bona fide event and not an artifact. If there's further occlusion, where the caliber of the upper airway further reduces, but there's still some continued flow of air, that's called a hypopnea, right? Which is hypo, under breathing. So that's called a hypopnea. Normally, to score a hypopnea, we would also have to record blood oxygen, and we're going to do that tonight with a finger probe. So when you're asleep, you'll see red light. At 10 o'clock, the finger probe light will come on. And the way it works is there's red light and infrared light, and there's differential absorption of the two light frequencies. And that differential absorption tells how much blood is actually in your capillaries, or what's called the saturation of peripheral oxygen. And you see here you have a further flattening on the waveform. And then, of course, when you look down at the raw data, you get a further reduction in amplitude, and this is the clinically significant event right here. Now, an apnea is defined as a total cessation. They're saying here 90% or more. And so this is a total cessation or occlusion. And that's a flat line. And so to get your patient's attentions, you want to tell them they're flatlining. And that's what you see here. Total flat line. And this is, it has to be at least 10 seconds or longer. So we call it wake up, gasping, choking, die in your sleep disease. Any questions on this? So it's a really good thing to have. If you want more, if you're operatories, let me know. On the back side, of course, some of what we've already talked about, but again, a really good summary. In a nutshell, this really is the fundamentals of sleep disordered breathing. So let's talk about a little bit in a little more detail what we just talked about briefly. So we're going to put on a cannula tonight. This is we're going to use an oral nasal cannula. This is what the waveform should look like in a normal, healthy, sleeping person. It's like breathing in, out. So this is the actual pressure. We're going to measure it two different ways tonight. A pressure waveform, which is what you see here, and a temperature waveform. Temperature better detects apnea versus hypopnea. Pressure is much more sensitive to detect normal versus flow limitation or normal versus hypopnea. So we have a quasi or kind of like a sinusoidal shape. Normal sleeping person is about 5,800 breaths per minute if they're normally 10 to 16 breaths per minute. So during the night, 5,800 breaths. I only get excited if it's like under 2,500 or above 7,500 or above 8,000. Then I start thinking, is there something wrong here? Like with a person that had an AHI of 81, back in January, his number of breaths was only 1,400 all night long because he held his breath most of the night. So the drop in muscle tone, that's key. You don't get that drop in muscle tone, you're much less likely to have apnea. So people that play the didgeridoo, strong muscles, people that play the double reed wind instruments, people that sing in the church choir, all those people that work out those upper airway muscles, much less likely to have sleep apnea. Flow resistance increases with sleep. Studies have found that supraglottic pressure resistance rises dramatically even in normal, healthy, asymptomatic sleepers. So that's normal, much more so in sleep apneics. So without that occurrence of the state change of sleep, the sleep disordered breathing doesn't have an opportunity to actually begin. So the sleep state is needed for airway problems to occur. So what happens during an apnea? This quasi-sinusoidal good breathing gets replaced by this, the flat line. Your patients are flatlining. So here we have 3 occurrences. These are the wheels of death. 1, 2, 3. Recovery breaths, happens again. Recovery breaths, happens again. And on a patient with severe sleep apnea, this happens all night long, regardless of body position. For some people, this only happens when they're supine, when they're on their back, and I'll show you a case of that shortly. Another key point here, if you measure anything other than airflow, it's an indirect measurement. If I stick my finger in a glass of water, I'm not going to drown, right? Because you don't breathe through your finger. So we're measuring it directly tonight. We're going to measure it. Everything we're using tonight exceeds the guidelines from the American Academy of Sleep Medicine for home sleep testing of sleep apnea. So what happens during a hypopnea? So instead of a total flat line, we have partial, right? We have a significant reduction in amplitude. Typically, it has to be at least a 30% reduction in amplitude. And in combination with that, we want to have at least a 4% desaturation. In other words, we want the peripheral saturation of oxygen that we're measuring. Could be measured on the earlobe. We're going to measure it on the finger tonight. We want to say at least a 4% drop or a 4% desaturation in combination with this change in the airflow amplitude for at least 10 seconds or longer. So oxygen deprivation and the wheel of death, keep that in mind. The hypopnea must have the amplitude reduction in airflow and must have the SpO2 desaturation to be diagnosed or to be classified as a hypopnea. So normal airflow again, sinusoidal, no obstruction, get a complete flat line, apnea, and a partial as a hypopnea. If we add one effort belt, tonight we're going to wear 2 effort belts, but if we add 1 effort belt, we can then differentiate between central, obstructive, and mixed apnea. And the reason for that is because no oral appliance in the world will be successful at treating central sleep apnea. So there's 3 types of sleep apnea: central, obstructive, mixed. Central sleep apnea is when the central respiratory mechanisms in the brainstem stop sending out signals. So think of it as a vacuum cleaner you have plugged into the wall. If you walk up to the wall and unplug the vacuum cleaner, the motor cessation shuts down, right? There's no ventilatory effort in the body, same idea. With an obstructive sleep apnea, there's a physical obstruction in the upper airway, soft tissues causing an occlusion, but there's still continued respiratory effort or ventilatory effort. And a mixed sleep apnea begins as a central and terminates as an obstructive, and it's usually treated the same manner as an obstructive sleep apnea. Probably well over 90%, 95% of apnea that's out there is obstructive, but central must be separated because there's no way you can treat that with an oral appliance. So there's your cannula, there's your effort belt. We have a body position sensor internal, just like it's in your iPhone or your iPad. As an accelerometer, we have the same technology in the MediByte tonight. You'll be wearing that. If we add the SpO2, the finger probe, we're going to measure the blood oxygen levels. That's this part right down here. And then if we add a second belt, we're going to put one on the chest and one on the abdomen, and that's going to let us look at paradoxical effort. And the reason for that is because now we're going to know if it's truly obstructive. It just gives us further confirmation. So paradoxical effort, if I plug my nose and close my mouth and I try to inhale and exhale, instead of when I'm normally breathing, my chest and abdomen go up together and go down together. If I plug my nose, close my mouth and try to breathe, my abdomen and thorax would go paradoxically. It's called paradoxical effort. So that confirms. That's what we look for in the tracings, to confirm an obstructive event. So that's what we're going to try to look for tonight. And then, of course, we're measuring body position, and if we have supine, we'll know that's a positional apnea. We actually get that quite a bit. It's surprising how often we see that in these courses. So when we combine all of these things, we end up with what's called a type 3 recording. And a type 3 recording is a classification from the American Academy of Sleep Medicine that they came up with in the 1990s. And they classified it as 1, 2, 3, 4. And that type 3 basically means it's unattended. There's no sleep technologist in attendance. So the American Academy of Sleep Medicine in 2007 had a paper. They call it PM, or portable monitoring, may be indicated to monitor the response to non-CPAP treatments for obstructive sleep apnea, including oral appliances. The technology they recommended in the same paper: at a minimum, the portable monitors must record airflow, respiratory effort, which is what we're going to measure tonight with the belt, and blood oxygenation. The type of biosensors used to monitor these parameters in the sleep lab are also recommended in the portable monitors used in the home. The Canadian Sleep Society said the same thing in their paper. They had Dr. Catherine Ashton McGregor, who's the president of the Canadian chapter of the AACP. She's a dentist, and she was one of the members of the committee. And they say level 3 monitoring devices which use a minimum of 4 channels, including respiratory movement or effort, 1 airflow, 1 ECG heart rate, and oxygen saturation are preferred over devices that monitor fewer variables, i.e. type 4 or peripheral arterial tone or oximetry alone. So this is the classification here I just mentioned a moment ago. So type 1 is a sleep lab test. Now historically there used to be 16 or more channels, but now some of the sleep labs are recording 28 channels. Hennepin County will record 42 channels. They're in Minneapolis. They typically would deal with patients that were too sick to go elsewhere, so some of their patients would die in the waiting room. They've actually had codes where, you know, I was there on an overnight years ago, I think in 1998, and one of the sleep techs, we were just chatting, he was telling me the story. They had 2 patients die, I think, in their waiting room in the previous 10 years because they were dealing with very sick people that other sleep labs didn't want to touch. That's the sleep lab who in the 1980s came up with REM behavior disorder. They discovered that new sleep disorder, what's called RBD, or REM behavior disorder. So you'll notice here that type 1 and type 2, for all intents and purposes, are the same technology. You might have more channels in type 1 than type 2. The primary difference, there is a sleep technologist in attendance all night long in type 1 in the sleep lab, and in type 2, they're not there. So the patient's in their own home. We're going to use type 3 tonight. And type 4 is more or less a pulse oximeter. Now, I generally don't recommend just a pulse oximeter because pulse oxes they're good for getting the severe sleep apneics, but they're not as sensitive for getting the mild and moderate cases. So you can actually miss a lot of information with just a pulse oximeter. Any questions so far? So when we do a type 3 test, these are the different types of sleep disorders we can actually look at and some of the characteristics. So obstructive sleep apnea, central, mixed, complex, positional apnea, hypopneas, respiratory effort-related arousals or RERAs, flow limitation, snoring, sleep bruxism, we'll talk more about that momentarily, and then of course combination CPAP and oral appliance therapy. This article was just published about, 6 weeks ago, 8 weeks ago, in the journal Sleep. And this is a multi-site randomized trial, portable monitors, using positive airway pressure auto-titration where the machine sets itself. Typically you go to a sleep lab and the sleep technologist would adjust a dial, and it's called titration, or setting the CPAP pressure just for you, and it's measured in centimeters of water. That's the pressure gauge. So what they did here was they had patients who slept at home, and they were diagnosed at home, and they were treated at home for their obstructive sleep apnea using an auto PAP, or an auto positive airway pressure device. And this was done in a multi-site study, Case Western Reserve View, a lot of prestigious institutions here. And what they concluded, a home-based strategy for diagnosis and treatment compared with in-laboratory PSG was not inferior in terms of acceptance, adherence, time to treatment, and functional improvements. So to summarize different types of sleep apnea and sleep disordered breathing, this is a summary here. When you see central sleep apnea, you have a flat line on both flow and effort. When you have an obstructive sleep apnea, you only have a flat line on the airflow, but effort continues. And a mixed sleep apnea is a combination of central and obstructive. Sleep apnea, of course, once we tally all of these numbers up, we then gauge how severe or mild the person is, or whether they're within normal limits. You could have a patient that comes in, they snore, their AHI might be 3 or 4, so they're normal, but they might have an RDI of, say, 9 or 10, because they have more milder sleep disorder breathing called RERAs and flow limitation, in which case an oral appliance would be fantastic. Particularly a lot of women will have more upper airway resistance. The ratio of male to female premenopausal is about 8:1, and postmenopausal is about 5:1. In pediatric, of course, anybody above 1 is considered abnormal. So let's talk about central sleep apnea. There's a question earlier, let's get to it. So these are the flat lines that we would see in central sleep apnea. You have a flat line at least 10 seconds or longer on the airflow, flat line on the chest, flat line on the abdomen. This is the sum channel. Think of sum as 1 + 1 = 2. If it was paradoxical, it would be 1 + -1, and that would also equal 0. So in this case, we've got a flat line right across, so that's central sleep apnea. This is actually in a good sleeper. This person, normal sleepers, healthy, good sleepers, will often have some central sleep apnea events during the night. Here's another one, all flat. Now here's a case we did at the AACP, I think last year in Baltimore. 2 nights. One's a Thursday, one's a Friday night. This person was on CPAP one of these nights. Which night do you think they're on CPAP? Top or bottom? They're on CPAP on the bottom? Top. So some people say top, some say bottom. Look at the number on CPAP. Look at the number without CPAP. That's their AHI. They got worse with their CPAP. Why? Why would that happen? It wasn't obstructive. They're central events. This was done with a MediByte Junior, but you still get your ventilatory effort. There's no effort here during the apnea. See this? There's no effort. Each of these is a central apnea. So with CPAP, what happens is that this person got worse because CPAP is not really indicated for central sleep apnea, just like an oral appliance is not. They're indicated for obstructive, perhaps mixed sleep apnea. So this person would have to get a more sophisticated ventilator, something called adaptive servo ventilation, or ASV. So what we ended up doing was just instructing this person to go back to their sleep doc and get retested with a more, with a proper piece of equipment. Because the ASV will actually analyze on a breath-by-breath basis your breathing pattern and adjust the pressure accordingly and actually start stimulating the peripheral chemoreceptors in your body to actually start breathing, getting you going. So this also underlines the importance of ongoing monitoring. Typically in a lot of sleep labs, what they do is once you've been diagnosed, they send you out the door, you go to a DME company for a CPAP, piece of CPAP equipment, and they often don't see you again. It's very rare for sleep labs to do, it's uncommon, shall we say, for sleep labs to do a lot of the follow-up testing. So here's a textbook example from the American Academy of Sleep Medicine. This is their textbook on diagnosing obstructive sleep apnea. You have your flat line on the pressure transducer, flat line on the thermal sensor, and you have continued ventilatory effort. You happen to have a desaturation. This is what it looks like in reality. Here you have your pressure transducer flat line, your flat line on the thermal sensor. You notice here the ventilatory effort is now going like here, it's in synchrony. They both go up and down at the same time. The chest and abdomen are going like this. So you have, let's say you have number 1 plus 1 equals 2. Here they're going opposite to each other. So the chest and abdomen are now like this. It's called paradoxical effort. So 1 plus -1 equals 0. And that's why we have a flat line on the sum channel. And that sum channel further confirms the existence of obstructive sleep apnea. So let's talk about snoring. 50% of the population snore. Number one complaint. Your patients aren't going to walk in and say, oh, my bed partner has peripheral desaturations. Their blood oxygen level is going down. No, what they say is they snore like a train. I was in the cafeteria a year and a half ago, and one of our employees says, Rick, I got a problem. I said, what's wrong? He says, I'm snoring. Is it loud? I asked him. He said, yeah, my wife says it's pretty loud. She's sleeping on the floor. What do you mean she's sleeping on the floor? Well, she's out of earshot, so he's snoring up here and she's down here, and so she's out of direct line of ear, sight, so to speak. And I said, well, what about earplugs? They don't work. Wow, that's loud if they're not working. So we did a test, and he came out at like 13.8. So I said, okay, tell you what, well, let's get you a temporary appliance just to see if you're a responder. And if that's the case, we'll get you to your dentist, get a proper custom permanent appliance made. So we just made one of Jameson Spencer's silent sleeps. So he ended up going from like 13.8 to 7.4 in one night. I said, okay, well, you're obviously a responder. It's going to work for you. So he went to see his dentist, got an oral appliance made, and now the couple's sleeping in bed together again, and everybody's happy. That's the kind of stuff that happens all the time. You just need to start asking your patients, do you snore? Now, you all have one of your front office people. They probably know all the patients by name and know everything that's going on. I know my dentist, her front office person, Donna, she knows whether I even open my pool. You got to open your pool this year, because I haven't opened my pool in a few years. I didn't find it warm enough. So this year I did open my pool. But she knows exactly what's going on, right? So everyone in their practice has someone that knows everything about their patients. You get that person to start a conversation, Do you snore? Are you on CPAP? Have you been to a sleep lab? So before we get into it, why do black widow spiders eat their males after mating? Stop the snoring before it begins. So we mentioned this earlier, the biggest part of your market right here is snoring. So let's take a look at that. So it's not difficult to do any of this, right? But your auxiliaries are really key to get this going. So who are you going to call? She's not even here. Okay, snoring is common in animals, but apnea is not. There's a bit of controversy in the literature about that. There are some people that suggest that bulldogs and kind of the mastiffs, the flat-faced dogs. I used to have a mastiff. He died last year, but I'm getting another one this year. But he used to snore. I mean, it was so bad, I used to have to leave the room. It was that bad. What's that? Get him an appliance. Yeah, we actually sold a product about 10 years ago to a researcher in the Northeast who was going to measure sleep and snoring in bulldogs. And I don't remember what happened to that, but there is a bit of controversy around that. So what is one feature seen in all the animals? They're all mouth breathing. And we're going to talk about that more this weekend with the design of the Moses appliance, but key point about mouth breathing. So from Queen's, an article from Michael Fitzpatrick and others, Queen's University in 2003, European Respiratory Journal. The chance of having apnea is lower if breathing nasally than breathing orally. So, and they say this mechanical advantage may explain the preponderance of nasal breathing during sleep in normal subjects. They took asymptomatic, healthy, good sleepers, forced them all to breathe through their mouths, and they all developed some type of sleep disordered breathing. So we're intended, we're supposed to breathe through our noses for proper breathing during sleep. So I'm going to play you two snores. This is actually recorded with MediByte. I'm going to play this snore, and then I'll play this snore. I call that one the cow. Now, this is 2 breaths later, and that's a fast Fourier transform analysis, gives you the actual peak frequencies of the snoring. But I'm going to play this one now. Completely different sound. You can hear the flutter in that one. Now, snoring can occur both on inspiration and expiration. So this is inspiratory snoring, and that's expiratory. So the small arrow shows you a pause, but you also see in the volume here. Now that pause is quite interesting because that's supposed to represent the maximal point of occlusion or opportunity for occlusion in the upper airway. And I'll play that and then I'll talk a bit more about that, what the significance is for that. Inspiratory, expiratory. Now the significance of that, I call this oink oink therapy, but it's really the Provent. If you ever try it, how many people have tried this? Anyone tried it? Just me? You've tried it, haven't you, Alan? Huh? Basically, it's a one-way valve. So you stick it on your nostril. It's disposable. I think it's like $1 or $2 a day. And you stick it on your nostril so you can breathe in just fine. And then the idea is that it creates a positive upper airway pressure, and it's an end positive pressure. And so by inhaling, and then the valves don't allow you to exhale very slowly. They allow you to exhale very slowly. So what it does is it maintains a positive upper airway pressure, and that prevents the opportunity for maximal collapsibility right here. That little pause is representing the pause, because during an inspiratory or respiratory cycle, you breathe in, there's a slight pause, which is what you see right here, and then you breathe out. And that's the point at which you got maximal collapsibility of the upper airway for apnea to occur, and that's why they came up with this therapy. Now, supposedly there's a newer one that I think has less resistance that they've got just recently had FDA cleared for snoring. I haven't tried that one. But my problem with this one is I had a lot of difficulty. I couldn't breathe out. I mean, I could breathe in just fine, but I had to actually kind of peel them down a bit, which kind of defeats the purpose.
Well, the studies on this one showed that it was about 50% effective, first of all. The other one that they did that's less effective, actually, is a non-prescription item now.
Right.
And it doesn't look much different. Yes, it's easier to breathe out, but they're not claiming any bigger success. It's just a little more comfortable. But if you go from, 30 to 15, you still have apnea. And so it's not in the range of effectiveness that an oral appliance is, or that much else is. But again, if they wear it, it's better than nothing. So this is what's happening out there today.
Yeah, I was hoping to find anyone who even does combination therapy between oral appliance and the Provent, but I haven't been able to find anyone that does that yet either. And then, of course, in Boston this year, they just released the new one. I think it was called the Winx. Was it from Apnea Cure? Which is it's a negative pressure, is it not? Where they actually, you end up sticking something in your mouth all night long, and it's about a 50% reduction as well.
That's all they get.
But the problem is that at the end of the night, you have a little container where, because of the negative suction, it actually sucks saliva out of your mouth all night long. And you're supposed to empty it every morning, although one of the VPs did tell me that they can collect up to a week's worth, which they don't recommend, but apparently they can. So here's the snoring volume table. We're going to see some of this hopefully this weekend. And here's a baseline. And then this is the follow-up with the appliance. This is from one of the prior courses. And so what we do is we break it down in 10 decibel increments. And anything below 60 we do not define as a snore. So we actually define the snore two different ways. We can measure snoring based on nasal resistance, which is vibration, high-frequency vibrations in the airflow. We can also measure snoring based on decibels or loudness or intensity, right? Because that's the #1 complaint from the bed partner. So you see here that 1.5% of the entire recording of the night, between 90 and 100 dB, that's loud. With the appliance, I went to 0. Between 80 and 90 dB, from 4% of the night down to 0. 70 to 80, 4% of the night to 0. 60 to 70 dBs, 4.8% down to 0.7. And then, so this is a really good example of success because we got these numbers down. And now from 72% at the lowest level, I went up to 88.5. So hopefully we'll see some of those cases, examples this weekend. That was using a Moses and recorded with the MediByte, right. So combination therapy. You can combine, for example, we talked about CPAP with oral appliances. You can combine positional therapy with an oral appliance. This is a street hockey ball, so I'm Canadian, so instead of a tennis ball, I used a street hockey ball. I'll tell you a bit more about that. In this case study, this is my father-in-law. Let's see, 2010. So March 2010, I found out he was diagnosed with atrial fibrillation. So I said to him, we got to do a MediByte recording. We got to screen you for sleep apnea. He goes, you see sleep apnea all over the place. Right? What do I know? I got a PhD specializing in sleep research and sleep. But I'm a son-in-law, right? So I'm a schmuck. So I didn't push it too much. And then he went for the electrical cardioversion, and it didn't take, where they shock you, and the AFib did not go away. So it was a May holiday weekend, Sunday night dinner, so I just brought a little MediByte Junior, and I brought it to his house. Didn't even tell him, and I had his daughter and his son say, "Dad, do the darn test. The equipment's here. Just do the test." And my mother-in-law was going crazy, overreacting as usual. If he dies tonight, you're never coming back for Sunday night dinner, right? So we did the test. I showed him. He doesn't even know how to turn on a computer. He called me one day and told me he lost his Google. So he's not a very sophisticated. He's 77 years old, right? So he was able to use the equipment perfectly, but he called up one night and lost his Google, and I'd explained to him, no, the icon is just not It's not in the same place. You didn't lose your Google, trust me. So we did the recording, and I went back the next morning. It was like 11 o'clock. It was a Monday morning because it was a holiday weekend. So I downloaded the data. First, he told me he never slept on his back, and it says here, supine sleep 49.2% of the night. So almost half the night he slept on his back. The point is, you can't believe your patients, right? When they tell you stuff, oh, I don't snore. Talk to the bed partner. I don't sleep on my back. Talk to the bed partner. So we did the test, got the objective data. Half the night he's on his back. Look what happens here. He fell asleep with a book in his hand. He's on his back. It says supine. That's his left side. Look what happens here. So you look up and down, draw a line. He changes his body position here. Look at the SpO2. It's perfectly flat. Oh, what happens here? It goes up and down. He went on his back. Oh, he rolled to his right side. That's okay. Went back on his back. Oh, wow. That's positional apnea. We look at the numbers. His AHI, for a person that does not have sleep apnea, his AHI was 46, but only supine, only on his back. So his AHI is 46 on his back. Not on his back, not total non-supine, 1.5. So we know anybody under 5 is within normal limits. So I said to him, you could be an astronaut, go into outer space, right, and avoid gravity, unlikely, or you could go to the sporting goods store and get a couple street hockey balls for $3, put him in a pair of stockings around his back, so one's on each kidney, and so when he rolls onto his back, they would stick up and, you know, be uncomfortable, and you'd roll over onto your side. So I actually wrote this up as a case study in sleep diagnosis and therapy. We did a follow-up test. I called him up after a few nights. I said, did you get the street hockey balls and get a pair of old stockings and tie a couple knots and put them there? He said, yeah, I think it's working. I'm able to sleep through the whole night. And I said, what do you mean? Well, I didn't know this before, but he used to get up every night at 3 or 4 in the morning, and his body, because of those, you know, wheels of death we talked about earlier and the changes in the hormones, he would be hyper aroused and he couldn't fall back asleep. So he would get up and leave the room and go read a book and come back to bed after an hour or two, after he could calm down a bit. So we did a follow-up test. I think this was May 23rd, 2010. This was June 10th, after the sleep conference. And look at the difference. This is strictly positional therapy. See, I was hoping to get him from 46 down to 16 and then get him into like an oral appliance because he had wanted nothing to do with CPAP as a retired dentist. But we got him down to 4, and that was scored pretty liberally. So from 46 to 4 by keeping him off his back, because, you know, when you think of the soft tissue of the upper airway being pulled by gravity against the posterior of the pharyngeal wall, he was okay with that. He was okay with gravity causing his apnea, but to suggest he had sleep apnea prior to that, you know, to think he was overweight or anything was quite upsetting to him. So that was a good case there. Now the other thing we talked about earlier, a bit about bruxism. So if you see patients with abfractions, morning headaches, wear and tear in their teeth, you can actually record EMG. So we started working with Dr. Gilles Levine at University of Montreal, and he recommended we record masseter temporalis and zygomatic arch, all reference to the mastoid process, which is right here, so we can put the electrodes on and actually do a sleep bruxism evaluation. What's interesting is in 2005, I think it was, the American Academy of Sleep Medicine reclassified sleep bruxism from a parasomnia. Parasomnias are disorders which occur during sleep but are not sleep disorders per se. For example, sleepwalking, sleep talking. They reclassified it from a parasomnia to a movement disorder. So Dr. Levine was telling us, he goes, there is some perhaps misperception amongst the medical community that because the sleep bruxism is now a movement disorder, they don't want dentists, there are some that feel dentists should not be diagnosing sleep bruxism. So really, why is that? It's all a political thing, but the point is that he suggested we call it oral facial movement only because it kind of just encompasses all sorts of kind of the oral facial, craniofacial issues. And, but of course, sleep bruxism does fall within dentistry. So we can actually record these muscle groups, and this is what it looks like on the recording. So here at the termination of this respiratory disturbance, you actually see the EMG activation. It's encompassed in this red rectangle. And we can actually now record phasic, tonic, mixed, and indeterminate bruxism. We have an association feature in the software that will actually associate each occurrence of bruxism with a respiratory disturbance. So in this particular patient, they had an AHI of 31, and at the end of all of these events, you can see the bruxism events.
See, I'd like to add one thing here. That is that there's no add-ons. When you get a MediByte, this is all in there. You can do this. You can do whatever you want to do. You can record bruxism. You can record snoring, sleep apnea. You can do EKGs. Whatever you feel you need to do, you have the power with this device to do it all. You can't do it all at once. There's only so many holes to put wires in. So you have to limit what you want to do. But the equipment's all there. And so if you happen to find a thing that you want to do EKGs on, that capability is there. If there's a need for you to do bruxism, it's all in there. It's not like, oh, you want this, it's an extra charge, or you want that, that's an extra package, or we have, it's all in there. And that's to their credit. It's an excellent device.
Yep.
Okay. My question is, you're measuring airflow with the nasal cannula?
And the thermal sensor,
And a
yes,
thermal
two
sensor.
different ways.
Right. How can you tell if they're breathing through their mouth? Because if they're not breathing through the nose, it would show no event. The event would show flat line if it's going through the nose. But how can you tell if there's mouth breathing versus the nasal breathing?
Our cannula is a patented oral nasal cannula, so we have an oral component to the cannula, and on the oral nasal airflow thermistor, there's also a sensor in front of the oral cavity and one sensor in front of each nostril. This article is on your memory stick, Cato and Levine from 2010. This is about a 30-page article which just talks about bruxism. And they talk about the difference between waking bruxing, which is usually stress and anxiety and nervous tic, and supposedly is something like, I think, 20% of the population, is sleep bruxism, which is a different cause. And what's interesting is they've mapped it out from 4 minutes before the sleep bruxing event all the way down. And what you see here is you got changes in respiration and what they call rhythmic masturbatory muscular activity. And these are the proposed physiologic changes that are going on. There's entire books written on this. And of course, this 30-page article is also on your memory stick. So really some excellent references and reading material to go into it in detail. We have one prosthodontist we work with. She does about 2 recordings a week, and all she does is sleep bruxing. And her attitude is, you know, that falls within dentistry. If she sees wear and tear in the teeth and abfractions, then she screens for sleep bruxism. And that's how she works with her local medical community. And says, look, I'm screening for sleep bruxism. If I find someone with severe sleep apnea, I'm just going to refer them to the sleep lab and refer them. Think of me as one of your best referral network channel partners. So I have sleep apnea. My AHI was about 8.3, but I was waking up with morning headaches, wear and tear in the teeth, abfractions. And once I started wearing the appliance, after the first, about 5 or 6 years ago, after about 3 or 4 nights, I'd wake up and wow, I felt huge improvement. So for me, even though I had mild sleep apnea, it had a profound impact. Morning irritability, just low energy levels. And you'll see that frequently with your patients. So this is what I mentioned a moment ago. This is in the standard report. So different, you know, oral facial movements, or in other words, sleep bruxism and respiratory events. So we have them broken down: phasic, tonic, mixed, total, and indeterminate. And then the association feature between obstructive central mixed apnea, hypopneas, RERAs, and desaturations associated with each one of these types of bruxing. So what I'm hoping to do is, I spoke with a prosthodontist, and because she's doing 2 patients a week, I'm hoping to actually get that data and analyze it so we can actually write that up, because I think there's some really valuable data that we can now pump out. So diagnosis versus monitoring. Just want to emphasize this point. A dentist cannot diagnose sleep apnea. A medical doctor must diagnose sleep apnea, preferably a board-certified sleep specialist. However, a dentist can screen for apnea, for bruxism, and certainly you can monitor oral appliance effectiveness. You definitely want to do that. Any good clinician wants to know if what they're doing works or not. Here's the case I mentioned earlier with the dentist as part of this course. I think this was March 2011. So when he walked up to me on Sunday morning, said, how'd I do? I said, oh, I didn't look. And then I did look, and I said, wow, that's a big improvement. And you can see here, snoring reduced, and then of course the SpO2, dramatic reduction. But the point is a profound impact. Even though it doesn't sound as great, it's a lot easier going from 50 to 15 than it is going from like 15 to 5. This is one I did. This is the father-in-law of one of our employees. He had triple bypass. He had been to a sleep lab in Florida. They diagnosed him with severe sleep apnea at 33, an AHI of 33. They tried him on CPAP. He was claustrophobic, you know, take this damn thing off my face. So I said, look, your father-in-law is in town. He's going to die because he's getting more of a workout. He was 72, getting more of a workout in his sleep than he is when he's awake. If we don't do something for the guy, he's not going to last long. So he was in a tent. So he did a test while he visited in town. He was from Florida, came to Ottawa, slept in a tent, and it was in July. And we did a MediByte test. We came out with 38, and the sleep lab said 33, so they're both low end of severe. I said, okay, well, let's do something. You can see the SpO2 here, up and down, almost all night long. The snoring volume's loud. Look at the change. Especially if you only look at this part of the night here. And here's where I think it came loose at the end of the night. I think that's what happened here. So this number would be much lower if we just looked at this part of the night. So I told him, okay, go back home, go see your dentist and get a proper appliance. He's already been diagnosed because I had a copy of the PSG test. That's what you want to do. When you have a patient who's CPAP intolerant, you want to request a copy of that PSG test because then you know what your baseline. Then you want to repeat your own baseline test like I did here. And we wrote this up in sleep diagnosis and therapy as well. I mean, you can do these things anywhere. This is actually one of Alan's patients. This is with a Moses appliance. 72 down to 6. That's pretty profound. Look at the snoring volume here. Baseline. Look at that snoring volume with a follow-up. The SpO2 is quite profound. Numerous continuous desaturations. Fantastic improvement there.
Those 4 marks are dropouts. Those are artifacts, the 4 big ones.
Yeah, and down here we've marked them. We've told the software. The software now automatically tells itself to automatically exclude those dropouts. Because sometimes people roll over, they make a fist, and the signal drops. It's called low perfusion in the quality of the signal.
Can I add something here? This is an interesting case because, so with this kind of result, she came in one day and she said, well, I'm going to have to go back on CPAP because I want to get Invisalign to get my teeth straight. I'm thinking, how stupid can you be? You're going to, you know, okay. So but she made the point that she'd rather, you know, this beauty was very important to her. And so the answer we have, no, listen, with now is, if you only do the anterior segment with the Invisalign, you can use a Moses because you're going to have the upper device anyway. Okay, look at the picture. If you want to do the lowers as well, make a lower suck down, a lower C. They know how, they can figure that out in the lab, and then you can keep changing if all you're doing is the front 6 because they're not involved. So you can maintain the jaw position with the posterior segments, but you're still doing Invisalign with it in. So this is a very interesting case. I was a little late for this. The idea came to me after the fact, but hey, the idea is there and I haven't forgotten it, which is important too. All these cases are interesting. You hear Rick saying that he writes these cases up as case studies. You have the means to do the same studies that he does, publish it in a local dental society, publish it in a state dental journal. They're looking for this kind of stuff. This is career-building stuff. You'll get referrals from dentists as well. Credibility is the name of the game, and it's all there. We have it. I don't know if he's going to be cruel enough to say it, so I'll say it. But the fact of the matter is that you have other devices. One goes here and measures everything, and one goes here and measures everything. The bottom line, you don't breathe through your fingers and you don't breathe through your forehead. You breathe through your nose and mouth. If you want to measure what's going on, use a device that measures through the nose and mouth.
This was part of one of the American Academy of Craniofacial Pain mini residency courses. But again, the point is that you can see the profound improvement from SpO2 here to here. It's much flatter, much improved, and you can see a dramatic improvement in apnea-hypopnea index. That's just in one night. So take-home message. Step 1, screen and ask. Do you snore? Key question to ask every patient that comes in. If you've got 2,000 patients in your practice, you've already got 1,000 patients that snore. That's the occurrence of snoring in the general population. So you got the take-home. This is one questionnaire that's available to you. It's already on your memory stick. Feel free to use that. You do want to do a home snoring and apnea test. Do you have it? Are you dying in your sleep? So there's a consent form. We often get people asking us, well, how do you know the patient's going to take it back? So we've added a paragraph in here that you can have the patient fill out and sign off. I've never yet met any practice, any office, any sleep lab who has never had a MediByte returned to them. It's a common question, but I've never yet met anyone who has not had a recording device returned to their practice.
Not only that, but we tell them, if you take it tonight, you must return it tomorrow. You get it one night, unless we're doing a 2-night study, which is another huge, wonderful possibility. We'll talk about 2-night studies. But I would say maybe 2 times in 6 years, and probably only once in the time Gloria's been there, they didn't return it on time. This always comes back. It's not an issue.
I think it's the way.
Hold on, click it on.
We are explaining to the patient how to put the MediByte on. We treat it with kid gloves because the wires are, important. They're not delicate. They're very durable, but we treat it very carefully, and we explain to the patient how important this is. And so if they respect your equipment and respect your office, they usually respect your rules.
They're very, again, with this particular item, they appreciate that it's expensive. I mean, it doesn't have a price tag on it, but they do. They appreciate it. They appreciate the service. We do this more than I think anybody because, again, I'm a dental practice. We have, 4 or 5 of these in the office. And the fact is that we try and get them out every night. You snore, take it home. It's free. That's my gift to you. Anybody in your family, you got a friend, I'll do it. Because they're going to come back if they're positive. This is the best practice builder. I mean, doctors are doing all kind of stuff. They're giving various things away. They're giving free services away. They're paying welcome wagon. They're paying sponsors. They're advertising on TV. This is the best advertising, and they're going to come back with this. And so it's very appreciated. Today, you can't pick up a newspaper consistently for a week and not realize how prevalent this is. So it's in their awareness, and they understand. You're gonna do a free screening, fine, and we'll talk about the implications of that screening and how to use it the next 2 days, or the next maybe 2 days. So
one of the nice advantages, if you want to do it all in-house, do it all yourself, you can do that. If you want to send us the data, as I mentioned earlier, you can do that as well. So that's an option that's available. You get the interpretation report, oral appliance therapy, or CPAP. Again, now you're on the clinical workflow. You can go one way or the other. Make sure you follow up with the patients, because after about a year, half of those patients should come back. Part the airway with Moses or die. Oral appliance therapy. And there's consent forms on your memory stick for oral appliances. And then your follow-up test. That's key. Always compare the baseline versus the follow-up. Where to go from here? Principles and practice of sleep medicine. The American Academy of Craniofacial Pain is an excellent resource and group for combining temporomandibular joint or TMD issues with sleep. And there's always the American Academy of Dental Sleep Medicine. So we've talked about some of the technology, how to identify and score sleep disordered breathing, when it's appropriate to perform a baseline follow-up. We talked about some of the association between atrial fibrillation, bruxism, daytime sleepiness. We're going to talk more about how to interpret the results later this weekend. And real quick exam, can't let you leave without this. What is sleep apnea?
Any prizes?
Oh, I don't think I'm going to give you that. Wake up gasping, choking, dying, your sleep disease.
All right, give him a cup anyway.
You have a cup?
Cup.
I do.
Cup. Who answered wrong?
Richard.
Richard.
Richard who? Richard, Dr. Richard Klein? I mean Keller?
Keller.
Okay, Keller
There's
gets a
mug.
cup. Gets a mug.
Bubble wrapped.
Okay, what's the most important thing to tell your patient who has sleep apnea? You're going to die. You're flatlining. There you go. You're flatlining and dying.
Could you pass this mouse pad down to Dr. DeWitt? Thank you.
So eons ago, humans invented the wheel. What wheel has increased the incidence during the second half of the 20th and into the 21st century? The wheel of death.
Who said that?
Dr. Wilkerson.
Again, he got two. Give him a pen.
Yeah, he's getting a pen. Could
The
you
answer
pass this
again.
Wheel of
awesome
death.
Braybon pen?
Well, this is an easy one. What's the one question you want to ask all your patients when you get back to the office Monday morning? There you go. I think everyone got that one.
All right, everybody got that one? Okay, everybody gets a t-shirt.
Okay, thank you.